Well, thank you everyone for joining us today, and thank you for inviting me to present. I'm going to be talking today about epidemiologic study design. First, by way of introduction, my name is Elizabeth Helsner. I am a chronic disease epidemiologist. I am the interim chair of epidemiology and biostatistics in the School of Public Health. And I have a longstanding interest in the epidemiology of age-related conditions, in particular age-related hearing loss, Alzheimer's disease, and more recently, I've become interested in studying factors associated with diabetes prevention and possibly reversal. So I'm just going to be running over sort of the major epi study designs and giving you some examples of what each of the study designs might be used for. So first, what's epidemiology? It's really the study of disease occurrence in human populations. We are counting health-related events in people relative to naturally occurring groups in which they're members, and that's what I'm referring to when I talk about populations. So I wanted to talk a little bit about what kind of questions epidemiology can answer, and it can really answer a lot. First, the most simple one is, how common is a disease? Are disease rates in the community changing over time? What factors are associated with changes in disease patterns? What is abnormal in the course of a disease or the course of somebody's healthy lifespan? How accurate is a diagnostic test? What are the risks for a given disease? What is the prognosis? Does treatment really improve the patient, or does it really just improve test results? Is there a way to prevent a disease? What is the underlying cause of the disease or condition? And how can we treat the disease most effectively? So this is kind of a very wide range of questions that can be answered using epidemiologic study techniques, and which is one of the reasons I got so interested in epidemiology in the first place. There are major health outcomes that we measure in epidemiology. I call these the 5 Ds. We measure disease, we measure disability, we measure death, we measure discomfort and dissatisfaction. So those are all the very sort of like negative sides of studying health, but there's other options that we can look at with regard to healthy aging, like longevity, how someone is able to recover from disease, and satisfaction with life and health. So these factors are studied directly in humans. So that's another thing that sets epidemiology apart from other types of health research. We're not looking at cell cultures or genes. We're looking at actual human beings and their experiences. So just some basic research principles. In epi studies, we're typically considering a primary health outcome, which we call the outcome variable, or a dependent variable in the statistical model. We're also considering a primary predictor or an exposure. And if you're thinking about that in terms of statistics, that would be an independent variable. And then in addition to that, we are thinking about covariates or extraneous variables that might affect the relationship between a predictor of interest and an outcome of interest. So those third variables that we talk about may be extraneous to the main research question, but might really influence the way that we interpret our findings. And those extraneous factors could be biasing factors, confounding factors, or effect modifiers. So you've probably heard of those ideas before. I just want to give you a little bit of an example of what I'm talking about here. So the simplest example of looking at a relationship between an exposure and an outcome is by setting up what we call sort of a classic 2x2 table in epidemiology, where you see here we've got the exposure on the left, smoking and non-smoking, and our health outcome on the top, lung cancer, no lung cancer, and we can calculate some basic measures of association. In the case of a cohort study, which is being expressed here, we could calculate something called the relative risk. So it's the risk of disease among people who are exposed to a given factor compared to the risk of disease in people who are not exposed to that factor. So for this example, we would look at the incidence of lung cancer out of all of the people who are smokers over the incidence of lung cancer over all the people who are non-smokers and take the ratio of those two. And in this case, in this example, we see an increased risk of a twofold higher risk among smokers compared to non-smokers. So in most of the studies that I'm going to be talking about today, we're going to be thinking about studying the relationship between exposures and outcomes in a sample that's taken from a larger population. So we start from a larger population of interest. That might be something like the population of Brooklyn. And we draw a sample from the population that hopefully is representative of our larger population. And then we study to see whether the disease of interest is present or absent in our study sample. And then we may be interested in looking to see what kind of factors are associated with the presence or absence of disease in that sample. And our hope is that by studying these associations in a smaller sample, we can then extrapolate our findings to the larger population. So examples of some populations that we might be interested in, this is to represent the population of Brooklyn. We may be interested in studying something in a sample of students. We may be interested in studying a disease and exposures in a hospitalized population. Or we also may be interested in studying a group of, a disease-specific group. So in this case, maybe we're interested in doing a study of breast cancer survivors. So those are just some examples of populations that we might be interested in. I just wanted to kind of run through the major epidemiologic study designs. So we have both observational studies and experimental studies. In the observational studies, we could have either descriptive observational studies or analytic observational studies. And so the simplest types of observational studies are the descriptive ones, starting with case reports and case series. Ecological studies and cross-sectional surveys. And I'm going to be going over and giving you some examples of each type of study in a moment. And then analytic studies that are observational would be a case control study design or a cohort study design. And then we also have experimental studies, and that includes randomized controlled trials. It could also include community-based trials or other types of experiments, perhaps before and after studies or non-randomized trials. So I want to talk a little bit today. I'm going to frame everything from the perspective of coffee. I am a big fan of coffee myself. I used to be a much bigger coffee drinker than I am now. I've noticed that as I'm getting older, I can really only tolerate 2 cups of coffee maybe per day. I used to be much more of a 4 to 5 cup of coffee a day person. Here's just a few quotes about coffee and how important it is. I love the David Lynch quote, even bad coffee is better than no coffee at all. So in my house, actually, I think that I'm the second largest coffee drinker. The first one being my 15-year-old son. So he's taken the coffee mantle from me in the house. So getting back to the EPI study designs, the most simple type of study is a study of one person. That's a case report. And I have an example here of a case report of a woman with Parkinson's disease who drank a cup of coffee in the morning and noticed that she had a marked improvement in her Parkinson's symptoms. And when she skipped coffee, she had a lot more stiffness and difficulty with her basic ADLs. And in this write-up of the case report, it was suggested that maybe coffee was the cause of her improvement. And so then the suggestion was made that it might be of interest to do a larger study looking at the association between coffee and Parkinsonian symptoms. So that's just an example of a case report. And then I guess the next step up from a case report would be a case series where you're looking at a number of related cases that would all be presented together. And case series are usually reflecting a new presentation, perhaps an emerging infectious disease where we've got symptoms that we haven't seen before in a clinical population. So case series would be the next step up from a case report. And then the next step up from there would be studies of disease frequency, which are cross-sectional studies. So they describe the experience of a population at a particular point in time. So I've got a picture of somebody taking a photograph. I think of these studies as being snapshots in time. They can be used to determine the burden of disease in a population or the prevalence. Prevalence is simply the number of people who have a disease in a population over the total number of people in that population at a specific point in time. And these kind of studies can be used to look for association between factors and disease outcomes. And in epidemiology, we're typically thinking about three different groups of factors: person, place, and time factors. So person-related factors might include demographics, individual risk behaviors, past medical history and comorbidities, dietary factors, lifestyle factors such as smoking and alcohol intake, maybe even religious affiliation, exercise activity, all that sort of thing. So those would be your person-related factors. Place-related factors are geographical differences, maybe differences by neighborhood, differences by housing type, differences in terms of how close or far away you are from the equator even. And then time factors are how the disease is changing, or the prevalence of disease is changing over time. And I just mentioned that prevalence is the number of people with a condition or disease of interest over the total number of people at a specific time. If we were interested in the prevalence of coffee drinkers, we would simply count up the number of people who regularly drink coffee in our population over the total number of people who are in the population at that time. And this is just an example from Epi class of how we would actually count up prevalence. So if we wanted to know what the prevalence of a particular disease is on May 15th, these lines represent cases of disease, and the dotted lines here represent a specific point in time during the month. And so I'm asking you, what is the prevalence of a disease on May 15th? In this case, we have 1, 2, 3, 4 people. 4 people with the disease, and then we would need to determine how many people were actually in the population at a particular point in time. And in this example, we have 2 people that were lost, because the D represents here somebody who had died. So 2 people were lost from our population at the point in time when I'm trying to count up prevalence. So in this case, it would be 4 out of 8 people in the population. Okay, so moving on to correlational studies. So there's 2 different types that we can do, these cross-sectional studies. The first I'm going to talk about is an ecological study. So correlational studies simultaneously assess exposure and disease. So we're looking again, snapshot in time, looking at both the exposure and the disease at once. They can establish the strength and direction of an association between the exposure and the disease. But they can't really tell us much about causality, because we're not really sure whether exposures are occurring before the development of a disease. So they're very good to use to generate hypotheses, but they're not really great for testing causality. An ecologic study is a study that uses summary statistics or aggregate data. Usually this kind of data comes from publicly available data like health departments, census data, and they can allow us to compare disease frequencies between different populations or in the same population at different time periods. And what we do is that we describe diseases relative to population-wide factors. So we might be able to look at the average age of a population, or calendar time, or health service utilization. What proportion of people have access to healthcare? What is the per capita food consumption of a particular food, or per capita alcohol consumption? So we wanted to compare 2 different populations. We can use this sort of publicly available data to see whether exposures of interest at the population level are associated with a health outcome of interest. So there have been some studies that have looked at coffee consumption per capita to see whether coffee consumption may be associated with various disease outcomes. So this is just giving you kind of a map of what coffee consumption is looking like around the world. Interestingly, I was kind of surprised by this, that Scandinavia has higher coffee consumption than the rest of the world, and higher in Canada. We have fairly high coffee consumption here in the United States, and of course, other parts in the world, South America, Africa, and so on, have lower coffee consumption. And so if we wanted to do an ecological study, one question we might be able to answer is per capita coffee consumption associated with life expectancy if we're looking at it globally? So here's just some examples. So Iceland ranks third in the world for coffee consumption and fifth in the world for life expectancy. Sweden ranks sixth in the world for coffee consumption and ninth for life expectancy. So all of these are fairly high life expectancies for these examples I'm giving you. Canada, ninth for coffee drinking, 12th for life expectancy, and so forth. So looking at this, based on this very sort of limited snapshot of data that I'm showing you here for these countries, you might come to the conclusion that it's very important to have high coffee consumption if you want to have a long life. But there are some problems with looking at data in this way. First of all, so all of these pictures here are pictures of coffees where they have, and pictures of countries where they have long longevity. Not only do they have high coffee consumption, they also have a lot of other things in common. Specifically, they're beautiful. A lot of them seem to be on water. There's probably high socioeconomic status in most of these countries. There's lots of other factors that might be associated with longevity, not just coffee. So as I said, in these studies, data is presented as summary statistics, and we look at a simple correlation coefficient as a measure of association. They're really good for generating hypotheses, but they're not good because we don't have information on each particular person in the study populations. And so we cannot say, for example, if we're looking at population level data on coffee consumption and longevity, that it's the coffee consumption that's really driving differences at the nationwide level in longevity. There are many, many other factors that may be associated with longevity. If we were to look at these things at the individual level, if we were to measure lots of different factors in each person in the study. And so that brings us to the idea that ecological studies are associated with this idea of an ecological fallacy, which is the belief that a correlation that we find between an exposure and an outcome at the population level also occurs necessarily at the individual level, when in fact it might not. So the implication here is that this kind of group level data can't be used for hypothesis testing unless it's a summary of individual measures. In other words, unless we had every person in our study and we were able to give them a questionnaire to ask them about their exposures. Just one more quick example of what I mean by ecological fallacy. This is kind of based on a study I was interested in doing a number of years ago. In the Red Hook area of Brooklyn. And so for those of you who have been to Red Hook, you know that it's a very interesting neighborhood socioeconomically. There's a very large public housing development in the center of Red Hook. And then there's much more sort of upscale housing towards the shoreline. And so if you were to say, take the average neighborhood household income in Red Hook, you would wind up with something like $75,000. But in reality, that number does not reflect the average income in Red Hook. Red Hook is two separate places, two distinct ways of living in Red Hook. So in public housing, the average household income is $24,423, whereas in the non-subsidized housing, it's much, much greater. So if we were to use this kind of summary statistic as a reflection of the income situation in Red Hook, that would be an example of an ecological fallacy. The summary statistic is not reflective of the real experience in the neighborhood. The thing that's really great about ecological studies is that because they're based on publicly available data, they're very quick and easy to do. They're inexpensive. You can compare disease rates in different geographic regions using surveillance data really easily. They're not expensive to do. And so all of those things are great. And so for those reasons, a lot of times it's a very nice first step, but they do have limitations. As I mentioned, this idea of the ecological fallacy, because they're really based on correlations. Those kind of studies are okay if you have a linear relationship between an exposure and an outcome, but these types of studies don't really detect subtle or complicated relationships like J-shaped relationships in statistics. And we also are lacking a lot of information that's important on potential confounding factors or outside factors that might be explaining relationships between exposures and outcomes. Okay, so how can we improve on a cross-sectional study? So taking a step up, as I would say, in quality, in epidemiologic data quality, the next step up would be a cross-sectional survey type study. So that would be a little bit different because we would have person-specific information. So every individual in the study, we would actually be able to give them a survey or get information on individuals from medical records, that sort of thing. And so we know we can measure exposures and measure health outcomes at the individual level. Again, though, because cross-sectional studies are kind of done at one point in time, a single survey, we can't say for sure whether an exposure of interest is causally related with an outcome because we don't have that temporality. We can just say whether there's a correlation between an exposure of interest and an outcome of interest. And this is just the way that we would split people up if we were doing a cross-sectional study. We would have a defined study population or study sample. We would gather information on each of the people involved in our study on their exposures and disease outcomes. And then we would kind of split them up into 4 groups, like the classic 2x2 epi table. Exposed and they have the disease, exposed they don't have the disease, not exposed they have the disease, and not exposed and they don't have the disease. And what we calculate in a cross-sectional study, the basic measure of association is called the prevalence ratio rather than the relative risk. And that's just the prevalence of disease in an exposed group compared to the prevalence of disease in an unexposed group. And as an example, here is a study of coffee intake and the risk of hypertension. So this is actually a baseline visit of a cohort study that was done. So this is what we're seeing here is actually cross-sectional data from the baseline visit of a cohort study. And you're seeing here what's going on with increasing coffee intake in terms of cups per day, looking at various outcomes of interest. So here they're looking at BMI, and if you're just eyeballing this, it doesn't seem to be much of a difference in BMI. Systolic blood pressure looks to be about the same across the coffee categories, diastolic blood pressure about the same. And cigarette smoking, how is that associated with coffee intake at this one point in time? So it looks like smokers are more likely to be heavy coffee drinkers. So that's just an example of cross-sectional treatment of data. So the relative strengths of cross-sectional survey studies are they're relatively quick because they're requiring only a one-time examination or interview or survey. Because of that, they can be less expensive than other designs. They can be really helpful in program planning. They're useful for health departments in determining what the relative burden of disease is in populations. They can really help you if you're in a position of influence to determine where funds might go. So you can determine the relative contributions or the relative impacts of various diseases or conditions in a population. And they can be useful in determining associations between variables of interest. So again, they're good for generating hypotheses. But they are limited by the fact that, we don't have the real ability to determine causal relationships because we don't have the temporal relationship. We can't uncover the temporal relationship because we're not studying a group of people as they move from a disease-free state to a disease state. They deal only with survivors, and what that means is that, especially if you're considering a study, say, of an infectious disease, and you did a cross-sectional study, and let's just say that it was a rapidly developing infectious disease. There's a possibility that the people who got sick really quickly and had more severe types of diseases and died would not be a part of your cross-sectional study. So sometimes we deal with something called survival bias. They're not really useful for studying rare health conditions, and I'm going to give you an example of a study that's good for rare health conditions in a moment. They don't identify risk or future likelihood of occurrence of disease because we don't have that temporal aspect. And I already mentioned that they're not the greatest for studies of explosive epidemics or acute short duration illnesses like measles or upper respiratory infections. So to kind of address the problems of cross-sectional studies, we move into what's, I guess, considered the gold standard observational type of study in epidemiology, which is a cohort study. And that is a study in which we're studying two or more groups of people that are free of disease and differ according to, you know, an exposure of interest. So we may be interested in seeing, for example, how people, like, let's just say that we split a group of people who have recently been diagnosed with COVID-19 into two groups. One group that has diabetes and another group that does not have diabetes. And then we follow both of those groups forward in time to see whether there are any differences in disease outcomes over time with COVID-19. That might be an example of a cohort study. But we're interested in following a group of people forward in time for the incidence of a given event. So there are a number of different ways to think about this. Let's say that we were interested in doing a study of the incidence of breast cancer, and we potentially could identify a group of women who do not have breast cancer right now. Perhaps we have to define what our inclusion criteria for the study would be. So maybe we'd say we're going to recruit a group of women who are between the ages of 28 and 35 and are cancer-free right now, and we're going to follow them for the next 20 years to see who goes on to develop incident breast cancer. So we're starting with, in that case, with a disease-free population. We're going to follow them forward in time to see who goes on to develop disease, and we may be interested in looking at a number of potential risk factors. One may be smoking. So we might stratify our group of disease-free women into smokers and non-smokers and see who is at increased risk of developing breast cancer over time. So what I've just described there would be a prospective cohort study. So we begin with a group of people who don't have our outcome of interest. We split them into exposed and unexposed categories and follow them for years to see what happens. Another type of cohort study is called a retrospective cohort study. And a retrospective cohort study is similar to a prospective cohort study in that we are interested in looking at people over time to see what factors are associated with the development of a health outcome of interest. But with retrospective cohort studies, we're actually doing all of that in the past. And by in the past, I mean that it's being done in the context of the medical record. We're not actually seeing people, say, like every 2 years. We're not having them come into a clinic and measuring them every 2 years. Instead, let's just say that we've got a stack of medical records from a clinical practice that span 10 years or something like that. Let's just say that they span between the year 2010 and 2020. And we're interested in seeing whether a disease or an outcome of interest develops in our clinical population over that 10-year period. But rather than actually seeing people and interviewing people and doing clinic visits with people every year, what we're going to do is kind of track that group of people in the medical record over time to look for the incidence of a disease. So that's kind of an example of a retrospective cohort study. And I kind of think of those as being studies that are all done in records rather than necessarily in person with people. So here's an example of a cohort study of coffee consumption and the incidence of diabetes. This is coffee consumption and risk for type 2 diabetes mellitus. And we find here their primary finding was that as coffee consumption increases, the risk of developing diabetes decreases rather substantially. And I would like to say that this is a finding that's consistent across a number of studies, that there is a protective association between coffee consumption and diabetes. Very interesting. So major strengths of cohort studies, especially prospective cohort studies, they both maintain the temporal sequence between exposure and disease development. You can assess various effects of an exposure. So by that I mean, let's just say that we're interested in coffee consumption as the exposure. Not only, if we have a cohort study where we're asking people about a bunch of different health characteristics that they have, we might be interested in looking to see whether coffee consumption is associated with cancer outcomes. We might also want to see whether coffee consumption is associated with heart disease and diabetes and so on. So you can look at a number of different potential health outcomes as they are related to an exposure. They're also good for studying new or unusual exposures. And the reason that they're good for studying unusual exposures is that cohort studies tend to be larger in terms of number of people involved than some of the other study designs. And so if you have a larger study sample, then the chances of being able to identify people with unusual or new exposures is going to be a little bit greater. You are able to calculate measures of risk over time and incidence rates. For those of you, I mean, I didn't define the difference between incidence and prevalence, but prevalence is the presence of a disease at one point in time. It's the burden of disease in your population, the number of people who actually have the disease right now over the total number of people in your population right now. Whereas incidence is a new case of disease that develops over time. So when I'm talking about incidence, I'm talking about newly identified cases of a disease. So cohort studies are good because they allow you to actually count incidence and cumulative incidence over time. Cohort studies are also good because you have, as an investigator, a little bit more control over how you are going to ask people about their exposures. As an epidemiologist and as somebody who's designing a study, you can determine exactly what kind of questions that you're going to ask people about their exposures. You can decide to use validated instruments. You can ask the same questions year after year, so you have better control over the quality of your data. And cohort studies, especially prospective cohort studies, are great because you can provide a complete description of someone's experience after exposure. And so you guys have probably all heard about this idea of the natural history of disease. Natural history of disease is when somebody moves from a healthy asymptomatic state into a subclinical period of disease where they may have some underlying disease-related changes that are not being shown clinically. Then you move to sort of like a clinical point of diagnosis. And then after clinical diagnosis, there are two different paths that a person could take. They're either going to be treated and improve, or they're maybe going to be treated and not improve and eventually go on to succumb to the disease. So the thing that's nice about these kind of prospective cohort studies is that they really allow us to capture the natural history of disease in a particular group of people. Major weaknesses of cohort studies is that they're very expensive. They can be inefficient for studying rare diseases because when you have a rare disease outcome, you might need to have a prohibitively large study sample to be able to capture enough cases. The example I always give is pancreatic cancer or something like that, which is a relatively rare health outcome. In the case where you have a very rare outcome, it's really best to use a case control design, which I'm going to be talking about next. So cohort studies are not great for rare diseases. And for some diseases that have a very long duration of follow-up, cohort studies can become prohibitively expensive. So that's just something to bear in mind. And then another thing is we also have to anticipate changes that happen over time, especially if we're going to do a study, say a 15 to 20 year long study. There sometimes are changes in diagnostic techniques. And so we have to be careful about the way that we're classifying people who have disease or have incidence of disease and people who don't with changing diagnostic criteria. And then other possible weaknesses, and in fact, this is a possible weakness of any kind of epidemiologic study, is that we don't have complete measurement of possible confounding variables at the study baseline. So let's just say that smoking is a confounder in the association between coffee drinking and risk of delivering a low birth weight baby. But if the investigator failed to measure smoking status at the beginning of the study, we can't really consider that as part of our assessment of the relationship between smoking and low birth weight baby. I mean, coffee drinking and the birth of a low birth weight baby. The other thing, which is a constant problem, is that exposure statuses can vary over time in our study population. So as an example here, with smoking, let's say a person between 1985 and 1995 smoked a pack a day. 1996, they quit. 1997 to 1999, they started again. And then 2000 to 2001, they switched over to a nicotine patch. So as you see here, it can get a little bit complicated when we're trying to measure exposures over time. Okay, so that's kind of what I realize that I am covering quite a lot of material in a short period of time today. So forgive me, but I just really kind of wanted to give you an overview of a bunch of different types of studies that we use. So the next I wanted to talk about is the case control study. And in a case control study, as I mentioned, case control studies are very good, good choice for rare disease outcomes. And what we do is we identify a group of patients with the disease outcome of interest. And then we also draw a sample of people who are similar to the case group, but do not have the disease outcome of interest. So we're deciding who's going to be in our study based on whether or not they have a disease of interest. And then after we've identified, so typically what we do is, like, say we identify, let's say we're doing a case control study of multiple myeloma in patients at downstate at University Hospital. So maybe we identify each new incident case of multiple myeloma, and then we try to find somebody who's perhaps being seen as part of, you know, a well visit, who's similar to the multiple myeloma case in terms of age and maybe gender and race. So that would be our control person. So each case is matched up with a control. And so after we have those two groups of people identified, then we take histories on everyone, ask them about exposures that they had in the past, and then we draw our conclusions about whether or not there's associations between the exposures and the disease outcomes. So this was a study, a case control study that looked at coffee consumption and the risk of endometrial adenocarcinoma in Japanese women. They identified 107 women who had this type of cancer. And then they also identified 214 controls who were age and area of residence matched to the cases. And then they asked them all about their coffee consumption in the past, and determined that for the people who drank the most coffee, they had the lowest odds of actually having this type of cancer. So they just comparing the cases and controls in terms of their reported history of coffee consumption. However, interestingly on this one, the association was only seen in postmenopausal women, not in premenopausal women. So as I said, they're great for rare diseases. You can use a smaller sample size for case control studies. They are very commonly done in hospital situations. They can be very cost and time effective, especially when you're using previously collected exposures. And by previously collected exposures, I mean, you know, things that you might find in the medical record about exposures. They tend to support causal hypotheses by establishing associations in case and control groups and sort of asking people about their exposures in the past. However, because we are asking people about exposures in the past, these kind of studies are subject to what's called recall bias, where sometimes people who have a disease are more likely to recall their exposures that may have been associated with the disease than are people without the disease. So sometimes there's bias introduced when you're asking people to recall their exposures. We can't calculate incidence because we're starting with people based on whether or not they have the disease. So we cannot be counting up new cases of disease. Sometimes choosing appropriate controls can be a little bit tricky. One of the big problems, especially if we are relying on data from medical records, is that you know that there are big differences in the quality of medical records based on who's doing the note taking and note keeping. So some people do very complete medical record keeping and others do not. So because of that, that can introduce some problems with measurement into studies. So that's case control. And then the last thing I wanted to talk about is experimental studies. So the way that I've been presenting these studies to you today is kind of in order of their utility in determining causal relationships between exposures and disease outcomes. So as you recall, I started off by talking about case studies and case series, which don't really give us very strong evidence for causal associations at all. Then I mentioned ecologic studies, which again are not good for looking at causal associations. Cross-sectional survey studies, while they are very interesting and they can show us whether there are correlations between exposures and outcomes, are also not great for causality. When we move more into cohort studies where we have multiple measurements of people over time, then we are getting stronger evidence for causal associations between exposures and outcomes. And then finally, the types of studies where you have the strongest evidence for causal associations are experimental studies. So there's a couple of different types of experimental studies that we can do in medicine. We can use them to assess preventions and treatments. And the big difference here is that you as the investigator are actually controlling the exposure. So there's the ones that you're probably most familiar with are randomized controlled trials that are done to evaluate the effectiveness of interventions, drugs typically, or say surgical techniques. And so basically what we're doing is we are randomly splitting a group of people into two groups. One group is going to get the intervention of interest, and the other group will either get a placebo or an inert treatment, or they will get the standard of care. And then we are going to see what happens in terms of outcomes, how those two groups differ over time. So the randomized controlled trial is the most scientifically rigorous method of hypothesis testing that we have available to us in epidemiology, and it really does provide the best evidence of causal associations if they're there. And as I meant, I think I already said this stuff, but we really want to determine whether interventions are effective, whether they're medical interventions in terms of medications, treatment techniques. They can also be used for health education, for example. We can randomize one group of people to a specific educational technique and another to a standard technique and see whether there are differences in outcome. So I just wanted to make a couple of points about the conduct of randomized controlled trials. So as I said, we do split people. We randomly assign people either to get the treatment of interest, or to a placebo group, or to a standard of care group. And doing that, we can use several different types of blinding. And so you probably all heard of double-blind randomized controlled studies, and I just wanted to make sure that everybody is familiar with what that means. So you can have single-blind, double-blind, or triple-blind studies. In the single-blind study, the people in your study, your participants, do not know what treatment they received. In a double-blind study, neither the study participant, nor the investigator knows what treatment the participant received. So if you've ever worked on a clinical trial, you'll see that you get these bottles of pills that are marked with a number, but they're not labeled with what the actual treatment is. So in a double-blind study, neither the study participant, nor the investigator knows what treatment was received. And then the last one is triple-blind study, and that's when the participant doesn't know, the investigator doesn't know, and the person who's doing the analysis of the data also doesn't know. So the idea here is to try to minimize any kind of bias that might be introduced by having either the investigator or the analyst know who was on the active treatment and who was not. And then last, I wanted to talk a little bit about community trials. And this is something that's of great interest in public health. These are experimental studies that are done in communities or at the community level. They often focus on mass education campaigns that are aimed at changing people's knowledge or attitudes towards health behaviors. And in community intervention studies, the exposure is usually given to subjects kind of on a mass scale. So there's a couple of different examples I can give you. One is there, in the early days of fluoridation, where it was determined that adding fluoride to water could actually help prevent dental caries in children. Entire communities would have their water supplies fluoridated, and then the results in terms of dental caries would be compared to communities that did not have fluoridation done. So that's an example of a community trial. So clinical trials provide the most reliable evidence in terms of causality of all the epi studies. If we randomize participants, we have some ability to control both known and unknown confounders, because by randomly assigning someone either to a treatment group or to a placebo group, we are also randomly kind of spreading out like a bunch of other potential confounding factors. So let's just say I'm taking people off the street and I'm like, you're going to get this treatment and you're going to get that. A certain proportion of that population is randomly going to, have a better diet than the next person. A certain proportion of people are going to be smokers, and a certain proportion are not. With random assignment, we're also kind of spreading out the potential role of these confounding factors between the active and the control groups. I mean, between the active group and the placebo group. So when they're well designed and conducted, they can really provide the strongest evidence for causality. But the major limitations for randomized controlled trials is they are extremely expensive, and that is why most randomized controlled trials of medications and vaccines and things like that are paid for by the private sector. You can really only study interventions or exposures that are controlled by the investigator. You may have problems related to changing therapeutics and people dropping out. That's often a problem with randomized controlled trials of drugs, especially if the side effect profile is not good for the active treatment. So they can be limited in terms of how generalizable the results are to a larger population. And sometimes they can be unethical to perform at all, especially if there is a known treatment that's effective and we want to study a new treatment. So there can be ethical concerns with clinical trials as well. So that is my overview of.
What about crossover?
Crossover trials.
Yeah.
Okay, so yeah, that's a good question. So with a crossover trial, you start with one type of treatment and you look at the effect in the people who are getting the treatment. And then so there's two groups. There's one group that gets the active treatment and another group that gets placebo. And so you follow them for a specific amount of time and then look to see what the outcomes are in each group. And then you measure that. And then you flip it. So the group that was on the active treatment then gets the control treatment, and the group that was on the control treatment then gets the active treatment, and you see what happens after the crossover. So people can act as their own control.